when we were coming up with the program, I wanted to try, I don't know how successful it's going to be, but to try and open up to some heated debates. I don't know how many Brits there are here, but a character called Mrs. Merton, who was a sort of spoof chat show hostess on British TV, and she had this catchphrase of having heated debates. So I'd like to have a heated debate, and the idea of these pros and cons is a little bit artificial, and you sort of deliberately want the two extreme views, and we all know the reality is somewhere in the middle, but that's what I want to try and do. I want to try and, let's take the extremes that drugs are never going to work in hypothalamic genetic obesity and really behavior is enough, or bariatric surgery is the best thing and we should be giving it to everyone or not. And I want to deliberately occupy those two extremes so that we can try and find the actual reality in the middle. And hopefully educate those of you who aren't aware of some of the nuances. I think that particularly comes around the bariatric surgery, where for a lot of people, certainly a lot of the lay public, and I think even with some medical professionals and scientists, that they think that all bariatric surgery procedures are the same. And I'm very grateful for Randy Seeley for producing a very nice review that I've hideously stolen from in my talk, really going over how the different surgeries are different. And similarly with drugs, that we need to be very clear where drugs are working and in which specific disease. So we've got this intersection between types of drugs or types of surgery, types of behavioral modification, and the specific disease. And you've got to be very clear at that intersection what you're dealing with and what you're talking about. And you've really got to look at the nuances of the data. A lot of the data often is very anecdotal, and there's obviously a real publishing bias in reports, especially around things like bariatric surgery and sometimes with drugs. So we have to, all we've got available is the published data. Hopefully in the hour or 45 minutes or so we've got at the end, where we can open things up. If anyone has got anecdotal experience, unpublished data, please stand up and use this as a forum to tell us what you know that we otherwise don't. So hopefully we can do that. So the first topic is the balance between behavioral modification and the use of drugs. I'm going to give a brief introduction, just laying some concepts and a couple of specific examples, nuance particularly around Prader-Willi syndrome, which has been my personal interest, but hopefully demonstrate some principles that are relevant generally. Then Frank Greenway, who's a professor here at Pennington, is going to put the pro side for drugs, giving some ideas of some of the drug targets that might be more appropriate to use in these sort of hypothalamic obesity. And then Linda Gourash, well known to many of you here, developmental pediatrician from the Pittsburgh Partnership, is going to tell us why drugs are irrelevant, and actually we can perfectly control hyperphagia and obesity purely through behavioral and dietary modification. And hopefully you'll all be convinced. So we've had a nice introductory talk from this morning demonstrating how we've got several levels of defect that exist in the differing conditions. So we've got usually a genetic defect, although in the case of craniopharyngioma, as we heard, an anatomical defect either from the tumor itself or from what the surgeon does after they go in there. And that's going to cause a number of differing phenotypes that produce the final hyperphagia and obesity. Obviously, for some of them, as we heard with SIM1 or MC4R or leptin receptors, we've got a specific defect in hypothalamic feeding circuits in particular, but also maybe involving the brainstem as well. We've got a number of not always clear-cut hormonal, particularly appetitive hormone changes, high ghrelin levels, low PP levels, high insulin levels, reduced sympathetic tone, which may be as a result of the disease process itself as well. This may, or inherently as a separate part of this syndrome, cause changes in metabolic rate, which may be a useful target away from hyperphagia. Many of the syndromes may have a more general neurodevelopmental defect, which means that the abnormality may not just be in the hypothalamus and the brainstem and feeding circuits. It may be more generalized, which obviously makes treatment potentially more difficult because you might solve one hypothalamic problem but still have problems. And then, as we'll hear about in a talk later in the session, the increasing importance of so-called homeostatic circuits, the sort of hedonic reward circuits, and I'm going to show a little bit of data from some of our functional imaging work showing how sometimes that can be important with some of these targets, and actually how it may not be that separable from the homeostatic control. And then we've got a number of ways that those particular phenotypes feed back in to cause the hyperphagia and overeating, but let's not forget that there may be other ways that we can target to treat other than trying to deal with the hyperphagia itself. So if we can prevent adipose tissue disposition, if we can alter body fat distribution, we might avoid some of the metabolic complications of obesity by reducing visceral fat and liver fat. And maybe if we can modify food preference towards healthier foods, that may also be another way of dealing with the problem. And then maybe we need to not worry about the obesity per se, but actually be more worried about the consequences of the obesity and finding the better ways to treat the outcomes, i.e. the diabetes, the insulin resistance, the inflammation. And there may be treatments that are good for obesity and diabetes, but maybe in these particular syndromes they're good for the diabetes, but not so good for the obesity, but maybe that's okay, because at least we can manage the diabetes, which is the thing that's maybe causing the problems. Oops. Now, obviously, the simplest treatment we've got is to replace the missing hormone, like leptin, and as we heard this morning, produce good effects to treat that. But with these more complex pathways, we've got a number of targets that we may need to think about. So, obviously, within the hypothalamus itself, on the top left, we can maybe try and boost a receptor defect, so find more active MC4R agonists to override a receptor problem. But maybe better is to bypass that, do a post-synaptic target, or maybe even better, find something that completely bypasses the block in our particular disease, maybe, for example, going through brainstem circuits. Obviously, we've got the possibility if we think that hormonal changes are contributing to the phenotype, and I think we have to be very careful that although we discover all these additional phenotypes in Prader-Willi and craniopharyngioma that we heard about this morning, the question is, are they actually contributing to the end result of the hyperphagia and the obesity? And that isn't always clear to me. But maybe we can try and lower the ghrelin levels, increase PYY, increase PP levels. Obviously, brown fat is a target, and increasing sympathetic tone. Drugs that are used in addiction are increasingly being used in general obesity, and maybe that may be a pathway that may bypass some of these blocks that we're seeing. And finally, a bit pie in the sky, but maybe we'll actually be able to find ways of changing neuronal development if we can diagnose these diseases earlier and actually alter some of the neurodevelopmental problems. So just running through some of the drugs that we've had and lost along the way, we had rimonabant, essentially acting cannabinoid antagonist, which blocks endogenous cannabis-like compounds. In meta-analyses in the general obese population, reasonable effects, 5% excess weight loss over placebo, but unfortunately the drug was removed from the market because of problems with depression and psychiatric side effects. So a small weight loss, remember, as you'll see repeatedly, the magnitude of weight loss for most anti-obesity drugs in the general population is 5 to 10% at max above placebo. That isn't a huge effect given what we're trying to deal with in hyperphagia. I admit that preventing further weight gain is important, but if we're trying to cause weight loss, those effect sizes are pretty small. And are we really going to expect anything better than in the control population in our hyperphagic syndromes? I think not. And then the other problem, of course, is that some of these drugs may have extra problems in our syndrome. So the one trial of rimonabant that Morris Angulo did in New York with rimonabant, there was a reasonable suggestion of some beneficial weight loss in a small number of subjects of 8 kilograms of weight loss on average compared to 1 kilogram weight gain in the control, but 50% of the patients had very unacceptable psychiatric side effects. So we've got a syndrome with an inherent behavioral problem underlying. So you add in extra drugs which have psychiatric side effects, they're very likely to be worse in this population. So that's a problem when we're trying to use drugs within these syndromic populations. We've got other drugs around, orlistat, the only currently licensed drug for fat absorption, moderate effects, 2-3% excess weight loss. Some newer agents, lorcaserin, a 5-HT2C, and agonist which doesn't have the problems of valvulopathy that the previous dextroamphetamine had, should be licensed soon, 6% excess weight loss, and then the combination of naltrexone and bupropion targeting mu-opioid and altering the melanocortin-4 system ranges from sort of 5 to 9% excess weight loss. For example, here in trial published by Dr. Greenway, who'll be presenting shortly. So, reasonable effects in the non-Prader-Willi population. Here's the combination phentermine topiramate, an anti-epileptic, and amphetamine-like substance again. Reasonable size, excess weight loss compared to placebo in non-syndromic obesity. But the question is, are these drugs going to work in syndromic obesity? They haven't been tried yet. Topiramate was tried in Prader-Willi syndrome with, in one study, a small effect to prevent weight gain, and in another study, no effect on weight. So these drugs we can try, but are they really going to work? Gut hormone therapies, so we have a variety of gut hormones that a majority are anorexigenic hormones, and some are, like ghrelin, are increasing. They have some advantages over potentially some of these drugs, that we naturally increase our levels of these hormones every day, every time we eat, and so the safety profile is likely to be better. They may have multiple sites of action. Many of them work through the hypothalamus, which obviously is a problem if our diseases are affecting the hypothalamus. Do they actually work? Although, as we saw using animal models, we may find they do. But some of them also have extra benefits of working through other pathways, including the hindbrain and the vagus nerve. Of course, they may end up going through the hypothalamus in the end, even via those pathways, so it's still debatable whether they will work. But increasingly, their use, not necessarily alone, but also in combination, matters to shop, showing very nice studies where you have effects like glucagon, which don't have an effect on food intake on its own, but when you add it in to GLP-1 agonists, you get a synergistic effect, or certainly additive effect. So I think we're going to increasingly see combination therapies, as you saw from the drugs of Quenexa and Contrave. These combination therapies are going to be increasingly used, and that may help bypass some of the blocks. So some of these may be useful in some of our syndromes. So in Prader-Willi syndrome, where we have high levels of ghrelin and low levels of pancreatic polypeptide, which we've shown are really present from even under 5 years of age, pancreatic polypeptide being anorexigenic, maybe overcoming these may have some benefit. So far, however, they haven't been helpful. The one trial of lowering ghrelin levels in Prader-Willi syndrome using somatostatin analogs, which lower ghrelin in a long study, wasn't successful. Now, part of the problem is that embarking on these studies in Prader-Willi syndrome and other syndromes is quite time-consuming. These are difficult studies. We'll hear from Mate later about how difficult it is to do these studies. And one of the important things I think we need, in addition to the proof of principle in animal models, which I think is vital before going ahead, we also need early-stage translational studies in small numbers of patients to try and get a clue as to whether it's worthwhile proceeding. We'd done a previous study with just 4 patients with Prader-Willi syndrome where we'd lowered ghrelin using a somatostatin infusion, lowering the ghrelin levels in blue compared to saline in yellow, and we showed no effect on food intake in 4 people. Now, that may have been grossly underpowered, but it may have given a clue that the longer-term treatment was unlikely to be successful. And I think, to get that commitment to go ahead and do larger studies, we need evidence from animal models, and maybe a hint from a small-scale proof of principle concept in translational medicine in the patients that it's worthwhile doing. And I think that's going to be needed before we can embark. And then just to sideline a little bit, that we know as well as these homeostatic pathways that all of these syndromes are affecting, we know increasingly about the importance of the brain reward systems and how tightly linked they are to the control of food intake, to food preference, and also linked themselves to the homeostatic signals. So we have a number of brain regions, including the orbitofrontal cortex, encoding decision-making and the reward value of food, the insular cortex, where the taste cortex is, ventral striatum, encoding reward motivation and drive, the amygdala, emotional responses to food. And these may be alternative targets. I'm not convinced they're going to be the sole target, but several of the drugs coming around, mu-opioid system alteration, some dopaminergic drugs may modify the system and may be alternative ways to alter food intake. So when we study these, as like we do in our lab, using functional brain imaging, and we show people pictures of food, as we heard it in the talk in craniopharyngioma earlier, we can activate a network of brain systems when we show people pictures of food, including those areas I mentioned. And in our study, what we showed is that when we studied the effect of both fasting people and also feeding people but giving them ghrelin, exogenous ghrelin, to mimic the high ghrelin levels you see in fasting. So you can see that on the left-hand side in orange, the ghrelin levels are higher than on the fed visit when they're given a breakfast in blue, and then we can give a exogenous injection of ghrelin and rather superphysiologically increase ghrelin levels quite high after the injection, and then we put people in the scanner, so we've got endogenous hyperghrelinemia in orange and exogenous pharmacological hyperghrelinemia in pink. Just to confirm, ghrelin is a growth hormone secretagogue, so we stimulate the growth hormone in pink with our ghrelin injection. And what we find is that both fasting in orange and giving ghrelin in pink increase the appeal of food, particularly for high-calorie food compared to when you're fed on the left, and the effect on low calorie is not as marked. So there is this biasing of your brain reward hedonic systems towards high-calorie foods when you're fasted, and we can mimic that by giving ghrelin, showing that ghrelin has an effect on food reward. This happens across the range of high-calorie foods, whether it's chocolate foods, other sweet foods, or even savory foods, although the effect always seems to be a bit less marked for the savory ones. When we look at activation in the brain to the site of those foods, we show that orbitofrontal cortex activation, the area that encodes reward value, both fasting again in orange and ghrelin in pink, increases the activation of the orbitofrontal cortex to those high-calorie food pictures, but it's not as marked for low-calorie, it's blunted. And we also see the same activation by both fasting and exogenous ghrelin to activate the hippocampus as well, and there's several studies showing that both fasting and ghrelin administration can increase the memory recall of food pictures that you've shown when you test people later. So evidence that we can modify the reward system towards food by these drugs. Now the hormone that's particularly useful is glucagon-like peptide 1, one of the incretin hormones that not only has an effect to increase insulin secretion, but also has action as a satiety agent, either directly in the brain or maybe through the vagus nerve to reduce food intake. It also reduces glucagon secretion, which helps blood glucose levels. And it also has some of its satiety effect through delaying gastric emptying. In the originally used for diabetes, it has benefits in not causing so much weight gain compared to other therapies for diabetes. And in non-diabetic obese patients, studies have shown that you can get moderate weight loss, occasionally some nausea, at least in the early stages, but with careful dose titration you can avoid that. And you can get, in this study, sort of 5 kilograms excess of the highest doses of liraglutide, a once daily injectable GLP-1 agonist. Great, let's use these drugs. We saw some data earlier in the craniopharyngioma mouse model that these drugs were effective in weight loss. Let's use them. Well, we've got to be careful. Some of our syndromes, these may be problematic. So I've been particularly wanting to use these drugs in Prader-Willi syndrome. There's several anecdotal reports of improvements in either weight and or glycemic control, and sometimes both in Prader-Willi syndrome. But let's make sure we know specifically about the disease we're looking at. So in Prader-Willi syndrome, we have several case reports, which Anne Scheinman will no doubt talk about a bit later, where there has been episodes of gastric necrosis and rupture and perforation, either idiopathically or sometimes related to acute binge eating in Prader-Willi syndrome. And that may be in part related to the fact that there is reduced vomiting in Prader-Willi syndrome, a high pain threshold, probably some abnormality, particularly in those who've lost a lot of weight, of gastric musculature, and delayed gastric emptying. And because GLP-1 theoretically can delay gastric emptying, we could make that risk worse by using this drug. So several studies have shown using gastric emptying studies, using Technician labeled meals on the right in children with Prader-Willi, that the average gastric emptying time was 102 minutes compared to 63 minutes in controls. And on the left in an adult study showing that 5 out of 8 adults with Prader-Willi syndrome had delayed gastric emptying. I've got a poster outside. You can show the results of 2 patients with Prader-Willi syndrome and diabetes that I've treated with liraglutide with benefits in their glycemic control, not really great benefits in their weight, although in one of them we helped prevent insulin-associated weight gain. But we did gastric emptying studies for safety reasons before and after 3 months of liraglutide titrating up to 1.8 milligrams over 2 months. And in both patients on the right, we doubled their gastric emptying time. And in one of them, it became abnormal up to 90 minutes. Now, neither of them interestingly had any symptoms of nausea or abdominal pain. But that is of, I have to say, theoretical concern. But if someone with that delayed gastric emptying went and binged ate, there might be an increased risk of gastric perforation. Diabetic gastroparesis is a contraindication for the use of GLP-1 agonists, and I think we therefore need to maybe consider some caution in their use. So although these drugs may be beneficial in other situations, we need to be careful at individualizing the treatment for this particular syndrome. So maybe we can find an excellent drug. So here's a patient from my Prader-Willi syndrome clinic who I inherited at the age of 18. She's of South Indian origin. genetically therefore predisposed to diabetes, diabetic since the age of 10, on insulin, metformin, and thiazolidinedione, came to me with a HbA1c of 8.4%, BMI of 42.1. Over the following, living with her parents at home, elderly Asian parents who really could not cope with her Prader-Willi syndrome, gave in every time she asked for food. And over the next sort of 18 months, her weight dramatically increased and her BMI went up to 49.4. Interestingly, her HbA1c didn't change that much, but that was with up titration of her insulin. We then found the magic drug, and by this year we've got her BMI nicely down to 38.6 and her BMA down to 5.9%, and I can now start her on growth hormone. What was my magic drug? It wasn't a drug. It was putting her in a Prader-Willi syndrome group home. So we got her into a group home. She's happier. She's off her oxygen. She's off her BiPAP for obstructive sleep apnea. Slight hiccup, as you can see, she went on holiday back to Bangladesh to see her family, and not surprisingly, her weight went back up. And then once we got back down. So maybe we don't need drugs at all. Right. So I've let the heated Colosseum debate begin.
I'm going to give the position in favor of drugs playing a role in the treatment of hyperphagia. And what I'm going to do is to try and use hypothalamic obesity as the model, since it's hard to find animals with Prader-Willi syndrome. And talk first about what do we know about the physiology. We know that there's an increased insulin secretion and that there's a reduced sympathetic tone in hypothalamic obesity, and what drugs have been used in the past and what has been their success. And then what is new on the horizon, and I'll try and mention about Belornib, which decreases insulin secretion and seems to increase metabolic rate or energy expenditure based on pair feeding studies. So hypothalamic obesity increases insulin secretion. There's bilateral destruction of the ventromedial hypothalamus is what's thought to cause hypothalamic obesity. The vagal tone is thereby increased, and that stimulates the pancreas to put out more insulin. And if you section the vagus nerve below the diaphragm in hypothalamic obese animal models, you can reverse the obesity or prevent it by sectioning the vagus nerve. And the rats that are made diabetic with streptozotocin, and then you put put pancreatic cells underneath the kidney capsule where they're not innervated by the vagus nerve, you can then prevent obesity with hypothalamic lesioning. And here's an example of what was done in that study. Let's see if oh boy, I fouled that up. Okay. I was going to try and use the pointer here, but I'm not quite sure how to do it. So, so you can see in the top line that the hypothalamic lesioned animals gained weight, but with hypothalamic lesioning and transplant of the kidney under the kidney capsule of the pancreatic islets, you can prevent that. And then the other two are just the controls. Hypothalamic obesity also decreases sympathetic tone. And when you reduce sympathetic tone, you get a reciprocal increase in food intake. So it's a driver of hyperphagia. And so there are at least two reasons for hypothalamic obesity to have hyperphagia. One is because increased insulin secretion drives hunger and increases food intake. And secondly, because of the decreased sympathetic tone. And the treatments that have been tried generate from those two disruptions. So the area of the brain where the obesity medications that, except for orlistat, act, or at least partly the area that's been damaged. So that makes treating hypothalamic obesity with medicines much more challenging. And I think that was one of the suggestions why maybe medicines won't be a very effective therapy for Prader-Willi syndrome or for hypothalamic obesity. Now, dextroamphetamine has been used in an effort to try and increase sympathetic tone in a general sense, 16 milligrams a day on the average. The weight gain in the 10 months prior to the institution of the dextroamphetamine was about 2 kilograms per month in the hypothalamic obese individuals, and then 2 years after treatment, the weight gain over that period was 0.4 kilograms per month. So clearly the weight gain was mitigated. There have been other treatments that have been tried. Triiodothyronine has been effective without too much in the way of symptoms, but it has had to create hyperthyroidism to be effective. Caffeine and ephedrine with 200 milligrams of caffeine and 25 milligrams of ephedrine hydrochloride given 3 times a day was able to reduce body weight by about 10% in 3 hypothalamic obese individuals, and one of these was able to maintain that for several years. So that was some success, but certainly not to the extent that that patient needed help. So there are other treatments that have been aimed at trying to decrease insulin secretion. 8 children with hypothalamic obesity were treated with octreotide for 6 months, and in the months before they were treated, they gained about 6 kilograms compared to a loss of about 4.8 afterwards, and their insulin levels were reduced by the octreotide. And that generated a double-blind and randomized trial of 16 patients. Obviously, randomized and double-blind trials are difficult in this group of patients because they're so rare. And the octreotide group gained 1.6 kilograms. The placebo group gained 9.1 kilograms, and the insulin levels were reduced. And here you can see on the left-hand panel the reduction in the insulin in the people who were treated with the octreotide, and in the opposite panel that it didn't happen in the placebo group. So since there's damage to the central appetite control mechanisms, it means that one probably is going to require drugs that work on the periphery rather than in the brain to treat this problem. Dr. Goldstone mentioned the CB1 antagonists. There are now CB1 antagonists that have been modified so that they're excluded from the brain, and in animals appear to give similar amounts of weight loss. And one can push the doses because one doesn't have to worry about the depression and suicide. But might say then, well, is there hope for a better drug? And so if what you'd like to have is a drug that would both decrease insulin levels and to increase sympathetic tone. And each of the strategies that have been tried up till this time have done one or the other, and they've certainly slowed weight gain, but they haven't been really successful in reversing the problem. Belornib is a candidate obesity drug that is now in phase 2. It works outside the brain to inhibit an enzyme called methionine aminopeptidase 2, and it increases energy expenditure in studies of pair feeding, and it decreases insulin levels in animals. So here's a picture of an animal study with belornib. The blue line is a mouse that's treated with a high-fat diet, and of course it gains weight. And the purple line is the same diet-fed animal, but on belornib at the same time, And as you can see, it comes down to actually below the level of the chow-fed control animals. And during that, there's a reduction in sugar, blood sugar, in insulin levels, and an increase in beta-hydroxybutyrate, which is a indication that it increases fat oxidation. And this is the phase 1 trial that shows that at twice a week treatment, the beloranib gave about 1 kilogram of weight loss a week over that 4-week trial, which is a fairly remarkable amount of weight loss. And the way this seems to work is that the methionine aminopeptidase 2 influences ERK, which is part of the insulin signaling pathway, and directs things away from increasing fat synthesis to increasing fat oxidation, increasing fibroblast growth factor 21, and fat oxidation. So, will beloranib be a treatment for hypothalamic obesity? It increases energy expenditure in experiments of pair feeding, decreases insulin levels, and it may be, therefore, a promising treatment for hypothalamic obesity. And the gold thioglucose model is a method of creating hypothalamic obesity in mice. And a pilot study was done to look at that possibility. So the gold thioglucose was injected into the mice in the blue part of the graph. They became sick from this for a period of time and lost weight, but recovered by about 10 days. And then you can see that they gained weight in comparison to the controls. And then the mice that were treated with gold thioglucose were either treated with saline, placebo, or with beloranib, and it was the other control was just a vehicle treated control. And as you can see, the mice lost 10% of their body weight in 10 days. And in the course of that, the food intake was significantly decreased. And so, in conclusion, hypothalamic obesity has increased insulin levels and reduced levels of energy expenditure. The prior drugs that have been tried to treat this have attacked only one of those problems. The beloranib decreases insulin levels and increases energy expenditure, and it causes weight loss and reverses the hyperphagia in mice that have hypothalamic obesity induced by gold thioglucose. And this suggests that drugs that work by a peripheral mechanism, with beloranib being one example, may well be helpful in the future to treat this difficult problem. And thank you, and I'll turn the program over to Linda.
Well, good afternoon, and I want to thank the committee for inviting me. It's a great honor for a person who's doing mostly behavior work to be speaking to scientists. Dr. Forster and I work together as the Pittsburgh Partnership. We call ourselves phenomenologists. Well, I'm actually a developmental pediatrician, and she is a developmental neuropsychiatrist, but a phenomenologist is roughly somebody who doesn't have any data. But we have a lot of experience, and we have a lot of black box experience. We started out in an inpatient setting with inpatients with Prader-Willi syndrome, and as it happens in this photo, every single person did have genetic Prader-Willi syndrome, and none of these people has been on growth hormone. The tall girl in the back is my height, and she was just from a tall family. when I first started working with this group, my primary focus was rescuing people from critical obesity and the medical complications. And it doesn't hurt, I think, sometimes to take a quick look at these photos to remember where this disorder can go when it's not properly managed. At the time when I started, I was actually kind of bored by behavior. It all seemed like one homogeneous, boring thing to me. Obviously, I've changed my mind, and like anything, when you get really interested in something, you start to see nuances and subtleties and possibilities that you don't see when you're standing outside looking in. So this is sort of what we've seen over the years. Both inpatient and outpatient, the bulk of our work has been with genetic PWS. We also saw a good bit of atypical PWS. This is a fascinating group. We had no idea what their genetic abnormalities were, but it was clear that they had a multi-gene or a multi-system thing going on. Some of them were actually pretty good imitations of Prader-Willi syndrome. Some of them we called DGIs, damn good imitation. But for the most part, the one thing they were lacking was the hypotonia. We saw some of this hypothalamic obesity, status post-craniopharyngioma, tough group of patients, a handful of Bardet-Biedl, and so on. I just want to draw your attention to the iatrogenic group, which has become a big part of my interest working with outpatients. And this is getting to be a bigger and bigger problem. I am the iatrogen myself. Whenever I put somebody on to an atypical antipsychotic or valproate. And this is an area that needs a lot of study and understanding. Am I missing? Okay. So for an opener, behavior modification works for hyperphagia. True or false? And I must have skipped a slide because there's the answer. Surprise. You were supposed to be surprised, not me. But anyway, the answer, in fact, is false. And it has to do, I guess the answer is don't press the button twice. Oh, this is a slide behind. What's going on? Okay, I'm going to use this. So the answer has to do with the distinction between behavior modification and behavior management. Behavior modification, yeah, this is always one slide behind. Go figure. Okay. Behavior modification can be used when the desired behavior can become its own reinforcer. Okay, it can become its own reward. And so even in Prader-Willi syndrome and in hyperphagia, you can use behavior modification, for instance, to toilet train. And it is done that way. Behavior management is done when in two situations, especially, it's needed, and that's when the undesired behavior contains its own reward, and or it's associated with very strong impulse. And in those cases, you need to use behavior management. What's the difference? Well, if you look in your rearview mirror and you see this, you are under behavior management. And anytime the state police stop giving out tickets, we all know what's going to happen. Okay, so you can't teach people not to speed and then stop with the reinforcers and the consequences. You've got to keep the reinforcers and the consequences going, and the state police know this. Okay, so behavior modification is time limited. Interventions and rewards can be withdrawn eventually. It's a learning paradigm for a new autonomous behavior. On the other hand, behavior management has to be ongoing. The rewards and controls cannot be withdrawn, and it is a learning program, a paradigm, but it's how to behave under a certain context, i.e. the behavior management, which consists of rewards and consequences. It works, this is a simplistic version of behavior management from our bariatric colleagues. Okay. And just to mention that in general, behavior management is mostly behavior prevention, and only a small part is behavior response. And so when we're teaching parents, we teach, these are our 5 main tools that we teach, and these are addressing all kinds of behaviors, not just the hyperphagia issues. So I want to emphasize the food security for today's purposes. And I want to say that food security starts with food control, but food control is necessary, it's not sufficient. Food control consists of the zone defense. This is what happens when the individual is in a place where they spend a lot of time. So school, home, school, and workplace, you can use the zone defense. This means you use locks. Yes, we still use locks, rules, alarms, and this precludes having to watch the person every minute. The man-to-man defense is what we use when we go out, so shopping, entertainment, transportation, any place. You also have rules, but you also may have incentives for good behavior, and you have constant vigilance. But more than food control is food security. Food security works to control behavior and weight at the same time. It works so well sometimes that people don't even realize that it's happening. And they think that it isn't really doing anything. It's working so well. And we have seen people lose their food security after 15 years of excellent placement, and some bureaucrat comes along and says this person needs more autonomy, and we have seen that become catastrophic. Okay, so they are not the same. Food security does not come automatically with weight control. And when you see a child or an adult with Prader-Willi syndrome who is slim, know that someone is working very hard to make that happen. It doesn't come automatically with calorie control because it's what's going on inside the individual's head. It's psychological security with respect to food. Because especially in Prader-Willi syndrome, but in the other hyperphagia conditions, at least that I have some experience with, food is stress. I've seen this in some of the RAD kids and some of the autistic kids, Fragile X kids as well. But food is stress, and in Prader-Willi syndrome, they are extremely stress sensitive, and that's where you get the other behaviors that are often associated with food, but really are more globally associated with stress. So we've tried to boil down the concept of food security into a format that people can pull up quickly when they have to think on their feet, and that's what parents and caregivers have to do. Food security consists of no doubt, no hope, no disappointment. Sounds brutal. It's about managing expectations. Okay. And it really varies from person to person, so you can't just say you have only these rules, or these are the rules for food security, and this is going to work for everyone. It really depends on the individual child, and every child and adult with Prader-Willi syndrome is a little different. And things that make a difference have to do with the individual's age, their overall level of anxiety, and especially I'm becoming more and more aware that it's really dependent on their past experience. So starting with no doubt, and this is a very shortened version of what we teach parents what the group homes are learning and doing. It helps them to have pre-plan of their menu. They need to know where their meals fit into the daily schedule. Some families use an unwritten routine, but it is a routine. It's not just, they are not playing it by ear. Spontaneity is not good for people with hyperphagia. Menus need to have a plan for when there's going to be any kind of disruption in the schedule, because weirdly enough, people with Prader-Willi syndrome will start worrying about where their next meal is coming from. Okay? If mom goes away for a day, they can come to the conclusion that they aren't going to eat until she gets back. So you actually have to tell them up front what the plan is while mom is away. Special occasions, they need to know what's going to happen. Okay? That means you need a backup plan for power failures, no time to cook, forgot something. And watching families who do this well, in many ways, is what has taught us what is involved in food security. And this can go in great detail, great floor planning. The second part is no hope or no chance. This has to do with the tendency for people with Prader-Willi syndrome to get their hopes up and imagine that they are in a food situation that when maybe in everybody else's mind there's not going to be any food, but if there's in the individual's mind, if there's hope, if there's a chance. Marabella this morning, thank you Jim for that video, was a perfect example of somebody who does not have food security, because in the video she did not. Because she had reason, for one reason or another, to think that maybe there was a chance she was going to get something from the ice cream truck. And so you can put all the locks on the fence that you want, but as long as she believed that there was a possibility or had a recent memory of it happening, you were going to get what you saw. And that was not an exceptional episode of behavior, by the way. So these are some of the things that people do to make sure that the individual doesn't get ideas in their head that are going to cause problems. We teach parents particularly that if you do give in, you try to make exceptions, you set yourself up for these expectations in the future. And I'm going to just run over these very quickly. These are some of the pitfalls that people get into. We talk about all of these. And then we teach proactively what to do at each age, because more and more we're appreciating the early experiences and how it feeds into later on attitudes toward food and high expectations. And we've seen some families who have been very proactive about this and very proactive about locking. And I believe that those kids have far much stress around food because they've never had those experiences. I'm going to skip that one, come back to it. And, okay. So a summary of the food security issues is expectations lead to disappointment, and disappointment leads to behavior problems. And so another way to put it is you have to put a lock even on the thought, not just on the refrigerator. And this, we do have a food security checklist on our website to assess your child's food security. Okay, so in order to do this, you have to have a paradigm, or it helps to have a paradigm, and from doing this, we have developed a paradigm. It's a rather fluid process of having a functional paradigm, which is nothing like the molecular paradigms that we have, but just a functional paradigm with respect to the hyperphagia, in particular in Prader-Willi syndrome. So for parents, we've developed the CAR model of hyperphagia. We start with hunger is the accelerator, moving the hyperphagia or the eating forward. And just the food for thought is, if you take your foot off the accelerator, does the car stop? And the answer is maybe, as with all things. But it's to point out that you don't need hunger to have hyperphagia. And that's a new idea to a lot of parents, because the assumption is if you can eat a lot, you must be very hungry. And this model is in part designed to give people some other thoughts about that. Second, we have the breaks. We'll simplistically call those the satiety signals. And there are emergency breaks, and for people with Prader-Willi syndrome, that's the lack of nausea and diminished pain. And also, there's even a lack of disgust in Prader-Willi syndrome that everyone who works with this disorder will comment on. We have lots of war stories illustrating their lack of disgust, and this goes to issues besides food. Okay, then we put the car on the hill. The hill is the food-rich environment, and the car is being pushed from behind with gravity, which we believe is the hedonic or the reward aspect of this. Some of it, the intrinsic reward of the food, and some of it is a heightened awareness. So the CAR model summary looks like this for all of us. And we believe that this is what it looks like, roughly, for Prader-Willi syndrome. We believe, and this isn't particularly controversial, that the satiety is diminished. And remember, the famous sandwich studies were actually behavioral studies. Hunger, we believe, is diminished across the lifetime with Prader-Willi syndrome, but it depends on the situation. And so, so it's possible that these nutritional phases that Dan is delineating have to do with this paradox of when they appear hungry and when they don't. Pain and disgust, and then reward, which we think is huge in Prader-Willi syndrome. People who work with the syndrome comment on how the children can sort of seem to go into a trance. They loll their heads back and forth while they're eating. They become very, very absorbed in the reward of the food. and they tend to go for the very highly rewarding, palatable foods. But they get a lot of pleasure out of ordinary lettuce, believe me. Okay? So we see this as almost a momentum and inertia paradigm, that in early childhood, before they've discovered reward and experienced reward, it's really hard to get them going. But once they get going, it's really hard to stop them. So in order to counteract this, instead of a food-rich environment, you put the car on the level where you have some food security. Whoops. Oh, I'm sorry. Let me see where that, yep. Okay. This is just to remind me to emphasize that I've actually, some families are not giving their kids sweets, and I think they're on the right track because of the reward component of the food-seeking behavior. So what about pharmacologic treatment? A couple of things is it's very easy to underestimate the magnitude of the problem. It's very easy to lose track of the fact that there's well, Prader-Willi syndrome is an insulin-sensitive obesity. Sometimes I'm not sure we know which direction to go because we have to take into account that the food issues are only the tip of the iceberg. There's actually a general lack of habituation in Prader-Willi syndrome, and they will go after medication, condiments, and flavored waters. All the families in all the group homes control these things, lock them up just as they do the food. Even more, they will overuse non-ingestibles. They'll overuse personal care products, shampoo, conditioner, aftershave, too much pet food for the pet, too much water for the plant, too much soap in the washer. Their hoarding and collecting behavior may be analogous to some of this. They want excessive computer time. If they like computer time, maybe even their skin picking has to do with the fact that they don't habituate. Their behavior around tobacco is exactly parallel to their behavior around food. And we've seen this from our European colleagues where tobacco is still more acceptable. And they will do the same kind of seeking behavior, stealing money to buy tobacco, perseverating on the tobacco, and so forth. Okay, so does Dr. Greenway, as a hyperphagia pill, my question would be, what would it target, since this is a global defect and not necessarily simply a hyperphagia problem? And what if it works? Is it going to give people more independence? That would be the goal. But on the other hand, there is the potential for loss of services because bureaucrats, by and large, understand life-threatening hyperphagia. They don't understand all the issues of very, very poor judgment and extreme impulsivity that characterize Prader-Willi syndrome. So to recap, behavior modification isn't behavior management. Reward, not hunger, drives PWS eating behavior. Food security principles do manage expectations and control weight and behavior simultaneously by reducing stress. PWS is characterized by lack of habituation for non-food reward as well as food reward. Pharmacotherapy research may have challenges in exploring the broader factors, and hyperphagia is the most dramatic and easily explained deficit of PWS, but it's not the only life-threatening behavior due to high stress sensitivity, high impulsivity, and poor judgment. Thank you.